Alberto Esquenazi, but it's always a great pleasure to introduce you, Alberto. So many thanks for being here, coming from America. And I have to confess that you are the American citizen I understand the most easily. But yeah, thank you for all your kindness, your science, and also your wonderful English accent or American accent. We properly understand.
Thank you.
It's up to you about observational assessment of gait influence on muscle selection for toxin.
Thank you. Thank you very much, Thierry. And what happens is my English has a very deep Southern accent. That's why you understand me well, so I appreciate that. So today I'm going to talk to you about this idea of using observational assessment of gait as a way to look at the complexity of the equinovarus foot. And this came out of really constant concerns and complaints that I've heard that when you look at the foot, it is very difficult to figure out what to do. And we heard yesterday a number of very excellent presentations about this. And clearly, it shows that there are many complexities. And when you ask the question, you get answers like, well, I use my clinical experience. And although that's very good, you need years of clinical experience to be able to do that. And I will tell you that even with years of clinical experience, I'm not sure that we are so good. So I've been trying to figure out a way to do this in a more methodical manner and in a way that will allow people with less training be able to do this correctly. So as a background, we know that the ankle-foot deformity is the most frequent position that presents in the upper motor neuron syndrome, and that it usually impairs gait. Really determining the optimal muscle selection to treat the abnormal spastic ankle-foot posture is very complex, and it requires not only a careful clinical examination and experience, but ideally dynamic EMG and diagnostic blocks. And we've determined, right or wrong, that the gold standard is 3D motion gait analysis accompanied by EMG, and that if you use those tools, then it becomes much easier to understand it. Why is it complex? Well, because there are so many potential combinations. And I am sure I'm missing a few of the combinations, but it is quite complex. So we use gait analysis. We looked at a patient like this, and it helps figure out what the problem may be when you have time synchronized EMG and you have data, kinematic data for the patients. We heard yesterday about IMUs. I've been trying to use IMUs as a way to assess. This is the Pablo system. I've been working with Tyromotion tirelessly to try to be sure that we get this correctly. It does tend to work for many patients, but not for all patients. Again, pathological gait creates a distortion in the timing process, in the assignment of stance and swing. But it works for a large number of patients. What we have in common is that we all can see, and if we are good observers, we might be able to use this to try to assess patients. Now, when you look at a patient on a video, you're looking at a patient in a uniplanar phase, and so that creates some complexity because you have to see the patient walk one direction, you have to put it in your head, then you ask the patient to walk in a different direction, and then you put it in your head and you assemble this three-dimensional idea. In general, visual assessment is not good for rotation, in general. You can use video. If you have a patient who has a very abnormal foot posture, they can't walk very far. So you take a video, and the video may help you because you can play it and replay it and replay it, and you can understand it. And of course, it does not provide any information on muscle forces. Yesterday, someone mentioned that EMG provides data on muscle forces. It's not quite right. We don't really get force data out of the EMG. So I decided to see if we could evaluate the value of video-based system to record movement. And by visualizing these postures, allow really observation that is very detailed, and in some cases allows you to see the superficial muscles in their action. And in doing that, it helps you with the clinical assessment. You could use this really as a proxy to determine with greater confidence which muscles are contributing to the maladaptive postures. And really the aim of this study was to summarize the principal findings of using what we've called VIVA, V-E-V-A, visual or video-enhanced visual analysis to assist with improving muscle selection for treatment with botulinum toxins. So that was really the principle behind this. So we use 2 cameras simultaneously, and what you're seeing here is just a patient using braces, doesn't have equine of ours. But we use this as a way that we could play it, replay it, we could slow it down, and you could see both images at the same time. Now, this requires a little bit of concentration. Your left eye looks at the left side of the screen, your right eye looks at the right side of the screen, and then your brain brings it together. Not quite like that, but you could do it like that with lots of practice. So we designed a prospective treatment study. This was set in our outpatient gait laboratory. We recruited patients who had stroke or traumatic brain injury longer than 6 months and had a spastic ankle-foot deformity that was amenable to treatment with botulinum toxins. They needed to be able to walk a minimum of 10 meters independently and with or without shoes. And then we allow them to use upper limb support but no braces. The participants were seen before botulinum neurotoxin injection. A proposed muscle injection list was created. Then we did the visual assessment using the video. And then we again identify which muscles needed to be injected. And then we did a follow-up between 4 and 6 weeks after. The main outcomes measure were at baseline and follow-up, we use self-selected and maximum walking velocity with and without shoes. We use step length and stance time symmetries. We use modified Ashworth score and Tardieu scale. And then we use passive range of motion of the ankle. We did not use active range of motion. So this is the kinds of patients that we were seeing. So it's a young woman with a traumatic brain injury. And then we were able to record the same data afterwards. So you clearly can see the difference before and after the treatment. Not perfect, but the intent was to use this data to figure out the strategy. So we recruited for this study 10 individuals. You see that there are 11 numbers in our list. That we actually removed one patient who developed problems in her opposite leg and could not perform the post-evaluation. She was in a cast for her other leg, and so we eliminated her. But here you could see that it was an equal distribution of men and women. The great majority were post-stroke, and you can see that we had more rights than lefts. And the majority of the patients were in an average 72 months post-injury. So these were more than 6 months. And there's certainly 2 patients, one with 129 and one with 225 months post. So this is some of the data that we were able to obtain. The self-selected walking velocity in this patient population was an average of 0.4 meters per second. So it's pretty slow. The maximum walking velocity was 0.6 meters per second. Quick question, what's normal walking velocity? Anybody? I'm sitting here with amongst the creme of physical medicine and rehabilitation, and you don't know what normal walking velocity is? Repeat? Depends on the age. I was going to say bull crap. That's not, age is a factor, but it doesn't really depend on age. Anybody? Between 3 and 4 what? Kilometers. Okay, 3 kilometers an hour, that's about reasonable. It's 1 point, lovely, 1.2 meters per second. That's very good. You get 1 point for that. And it does vary. Age is not, repeat that? Yeah, sure. It's 1 to 1.3 meters per second. It's the range. Women walk a little bit slower than men because they tend to have a little bit shorter stature. That's the reason for that. And age plays a factor, but it's not an independent factor. You can be old and walk fast. Now, if you're old and walk slow, prepare, you're going to end up in a nursing home. I can tell you that. So anyway, as you can see, this group walks very slow. Step length, as you can see in the baseline, 0.4 meters for the paretic limb, and the stance time was 0.8 in duration. What you see is that at follow-up, we had significant changes in walking velocity, an improvement of 21% in an average for self-selected, not as much for maximum walking velocity. There was improvement in step length and a little bit of improvement in stance time. Now, interestingly, when you look at walking with shoes, the changes are not as significant. And that is because the shoe hides the deformity and protects the foot. So so from this, we look essentially at characterizing the deformities into 3 major groups. So this is a patient, an example of a patient that has equinus with toe flexion. And as I said, the nice thing about this is that we could just bring it back and play it slowly. And we were able to observe in much more detail what was going on. Okay? The second group that we found was equinovarus with toe flexion. And you remember I said that you might be able to visualize some of the superficial muscles. If you pay attention, you may be able to see here, in this particular case, the tibialis anterior pattern of activation. So you can see the tibialis anterior triggering on in the swing phase. And then the last pattern that we saw was equinus. So here are the 10 patients. And what we did is we did physical examination, clinical assessment, and came up with recommendations on the muscles that were selected. So what you see here are the muscles that were considered for injection on the 10 subjects that we had full follow-up. Medial lateral gastrocnemius, tibialis posterior, flexor digitorum longus, flexor hallucis longus, extensor hallucis longus, tibialis anterior, soleus and rectus femoris and medial hamstrings, and for those patients that had proximal issues. But what you see here is that really the focus was primarily based on clinical assessment into the gastroc, tibialis posterior, FDL, and soleus. So that was really what came out of this observational or of this clinical assessment. Now, here's the same data after we viewed the video and carefully assess each patient on video. And then we assign, in this case, now you see the dosing that we assigned. This was Dysport as what we inject. In yellow, I've put the same muscles, so no change. The red muscles are all the additions. So you can see that even in the equinus, number 3, we added tibialis posterior because we could see that there was a little bit of that ankle inversion. And you could see that was true in a number of those patients. FDL, FHL, EHL, and tibialis anterior became muscles that were quite noticeably active. So you can see that it can make a difference. Now, why is this important? All of you can do video in your office. You don't need fancy equipment. You already have a phone. If you use your phone, you could use maybe your resident's phone or your aide's phone, and you can then pour that data in. Or you could have 2 simple cameras. Now, they're very inexpensive cameras that you could set up on a wall and use them in a corridor and record. And so you could do this observation very easily. It doesn't take a lot more time. That is really the aim, that you can take this as a message to home. I can do this. I don't need fancy equipment. I don't need expensive equipment. I can do it. Not perfect, but it shows that there is improvement. Why do I say not perfect? So this is modified Ashworth score. You could see that all of the patients showed improvement except for patient 3, who stayed the same in the post-assessment. But at least Ashworth improved in all of these patients. You can see that the Tardieu score is definitely a better way to assess these patients and improve in all of them except in case 8. So as a result, we know that equinos with toe flexion, equinovarus, and equinos were the most prevalent ankle-foot deformities in this population. Self-selected walking velocity and Tardieu were most sensitive markers of change in this study, and 9 of the 10 patients had the treatment adjusted after the visual evaluation was performed. In conclusion, physical examination supplemented by slow motion video analysis helped identify underlying spastic muscles that can cause ankle-foot related gait abnormalities. Likely, the visual evaluation is not as accurate as dynamic EMG, but it does help. 3 abnormal foot-ankle patterns were identified and confirmed using this technique. Equinovarus with toe flexion was the most prevalent, 6 out of 10. Equinos with toe flexion in 2 out of 10, and equinos alone in 2 out of 10. Some variability on muscle selected was evident within the same patterns across patients. And of all of the tools that we use, our findings show that improvement in the self-selected walking velocity was the major indicator for functional improvement after botulinum neurotoxin injection. And I hope that this study demonstrates positive changes in temporal-spatial gait parameters following botulinum toxin injection in patients with chronic hemiparesis. So as they say, in a big puzzle, you need all the pieces, but you have to have one key piece. And in this case, it happens to be that man. So I'll end with this because I was surprised. The horses last night were spastic horses. And if you don't believe me, just watch them. See how they walk all with a little bit of an adducted gait? So, with that, many thanks. I appreciate it.
Please. Micro. Okay. And a lot of equinus also.
A lot of equine.
Okay.
A lot of equine.
Thank you for this very. It speaks to me video. You know. So, do you have some question in the audience?
I need questions. I can't go home without answering. Yes.
Thank you for this presentation. What is the result about the toe flexion? Do you have results about the flexion of the toes after what you did?
Yeah. Sorry, I have to use the microphone. Yes, toe flexion gets relieved by injecting the flexor hallucis or the flexor digitorum longus. Was that your question?
Yes.
Yeah. So it improves, and in fact, there is a previous study. If you look at the pivotal data of the Dysport trial on lower limb, one of the findings that we had is that patients who got injection into the toe flexors did better. And I was also part of the pivotal trial for the lower limb for Allergan. And in that study, clearly we show that if you inject the toe flexors, FHL, FDL, as part of the gastrosoleus complex, you get faster walking speed. You do better with that. So if you don't inject it, what happens is that it becomes a restraining muscle. And so you need to relax it.
But for some of our patients, after this kind of injection, there is still toe flexion, and sometimes it could be the quadratus plantae that is one flexor that is not assessed.
So remember that quadratus plantaris does not curl the toes. You're talking about the short toe flexors, the intrinsics of the foot. So you can inject those. There is an easy way to identify that. You can look at the position of the toes to determine if it's the intrinsics or the extrinsics that are flexing the toes and make a judgment on that. That is easy to do visually. And the way I do it is I ask the patient to stand up and simulate a step. Their paralytic limb will stay in the back. That stresses the ankle, and as it stretches the ankle, it'll put tension on the toes. Okay?
I'm sure this is known by the surgeons here, but I reviewed a really nice paper from Japan this summer that showed through the knot of Henry there's a lot of overlap of the tendons between FHL and FDL. So pointed out you should always do both, and many people don't do FHL, but they're not realizing that the tendons are crossing over.
Yeah, if you remember the anatomy, you're very correct. It crosses over, and so it's important to understand that. And injecting both, if you're already injecting FDL, all you need to do is retract your needle just a little bit, move a little bit more towards the tibia, and the posterior tibia, the middle edge of the tibia, and you'll get the flexor hallucis. So it's a very simple procedure at that point. It's scary when you don't know where your needle is, so if you use ultrasound or electrical stimulation, it works very easy. Please.
Thank you, Alberto, for this wonderful talk. Just a testimony for telling you that I share your opinion that we need to make video of all the patients. I don't think that we have to do that on our mobile. I think that the material for doing that is not so expensive, that every center should have that. Perhaps it's the time for SNOF to give recommendation for have the same manner to do the video for all patients. And it's very interesting on the pedagogic aspect. For students, it's interesting for decision, and it gives more things for tele-expertise, for doing that in video with a center very far from your expert center. The main point is that we need to have global video with the same manner to do that, with standardized video.
Great idea. To have a standardized approach to video is a great idea. I use the phone as an example. I agree with you. At least in the US, we're not allowed to record with our phones because that's not HIPAA compliant. So it's better to put it. Now, I will tell you that my hospital, my laboratory hates me. And why do they hate me? Because I have the largest cloud storage of anybody in the hospital. I have thousands of videos stored in the cloud. Don't tell them I have thousands of videos stored under the ground in my laboratory. That's a different story, because it goes back to when I started doing gait analysis. So there are thousands and thousands of this. I think your idea is a very good one, which is we should try to look at the possibility of creating a standard video setup, which shouldn't be that difficult. It should give you a length and a width, and then how to set the cameras. And if everybody recorded in the same manner, it would be very useful.
We have the same problem for storage of video.
Yeah.
And we have, there is big crowd
Yeah.
for radiologists.
Yeah.
We have asked if we have the possibility to put our video. And it was a real problem with the radiologists on the possibility to put our video on their cloud.
Yeah, it's you know what I said to my hospital administration. I said a cloud storage is going to cost a couple $100 a year. I'll happily pay for that, so that we don't have to fight. They said no, it's okay, we'll pay for it. There was one more point that it's I think of value about video, and that is patient education and patient communication. I think Paul mentioned this. Patients don't tell to remember how they looked before. But if you show them their video, suddenly they, oh, I clearly remember it was terrible and now I can walk better. So.
Center. Sorry. If you do a standardized video, you give the possibility to share opinion, intel expertise about patient. So you give the possibility of center with less expertise in neuro-orthopedy to have an opinion on the patient and not to just discharge the patient to you and you give the good words, you know. And I think that a good way to do neuro-orthopedic, and that's the way that we do that in our country and area in the southwest of France.
Good.
Okay, I believe your patient already had a toxin injection before. Did you compare the data of post-toxin usually the patient usually had and after the modification induced by the video?
That's a very good question. Only about 1/3 of those patients had been injected prior, so not all of them. And look, it's a small number. That's why it's called a pilot study. It was really intended to just show, does it make a difference? I think that the piece that it's most critical to me is I had my fellow and I had one of my residents do exactly the same exercise. And they arrived at the same conclusions without seeing what I had done. So to me, it kind of levels the plane so that everybody gets to do the same thing. And so going back to your point, it is really not only an educational activity, but really a way to share the information in a more pragmatic manner.
Merci, Thierry.
Oh, hold on. I need to put, you're going to speak in French?
But yes, you will speak in French.
I'll kind of borrow your earphones. That way I will hear the question correctly. Go ahead.
Oui, merci beaucoup pour votre présentation. Alors, je partage la discussion sur la visualisation en fait, de ce qu'on fait avant et après, non seulement pour les patients, mais aussi pour nous-mêmes, parce qu'on ne se rappelle pas forcément toujours comment ils étaient. On peut se poser la question aussi d'une simple plateforme d'appui pour voir effectivement comment est le déroulement du pas avant et après. Ce n'était pas là-dessus que je voulais revenir. Moi, je suis admiratif de voir une disparition aussi rapide de la flexion de la griffe des orteils qu'avec une spécificité d'injection dans les longs fléchisseurs des orteils. Et je ne partage pas complètement, ou j'ai mal compris peut-être, votre point de vue sur le carré plantaire. Le carré plantaire, pour nous, enfin pour moi en tous les cas, biomécaniquement, si on reprend toute cette biomécanique de dissection et ensuite voir un petit peu, c'est le prolongement même du long fléchisseur des orteils. Donc en fait, on y associe, nous, pratiquement chaque fois, une injection effectivement du long fléchisseur des orteils, mais aussi du carré plantaire. Ça, c'est la première des choses. Et puis ensuite, il existe souvent des attaches, entre guillemets, avec le long fléchisseur de l'hallux et le long fléchisseur des orteils, ce qui fait que si on ne fait pas les deux, et à travers quelques centaines de dissections, j'ai retrouvé ces attaches pratiquement dans 90% des cas. Donc systématiquement, nous arrivons à faire ceci. Puis ensuite, on complète pratiquement systématiquement, parce qu'il y a les griffes intrinsèques, ça existe, les griffes extrinsèques, ça existe, les combinaisons griffes intrinsèques et griffes extrinsèques, ça existe. Donc pour moi, l'examen clinique n'est pas forcément même ce que vous nous apportez, qui est très intéressant, bien naturellement, dans l'examen clinique avec la précision que nous avez donnée, ce n'est pas aussi systématique que ça lorsque nous sommes en appui. Et donc, en fait, nous prolongeons le plus souvent l'injection avec le court fléchisseur des orteils et pour l'hallux, l'abducteur du 1 et le court fléchisseur du 1, puisque, bien sûr, ces deux muscles ont deux faisceaux qui se complètent, puisqu'ils ont une complémentarité. Le faisceau médial de l'abducteur du 1 est en partenariat avec le faisceau latéral de court fléchisseur du 1, et le faisceau médial du court fléchisseur du 1 est en partenariat avec le faisceau médial le faisceau oblique de l'adducteur du 1. Donc, pour moi... Qui est-ce qui veut que je répète? François. Bon.
Thank you for the anatomy review. I think it's important. But it is, what you need to remember is that we don't have enough botulinum toxin for all of the muscles we need to treat. And so we need to be more selective. I tend to inject the plantaris muscle or the short toe flexors when I see that as being a major role player. And if I have a cavus foot, I will certainly inject that. So it is something to keep in mind. I don't disagree. If you're doing surgery, by all means, you're already there. Get rid of it. If you're not doing surgery, and poor us who don't have access to the open leg, and we have to be more selective, try to be more selective. That's my only message. So thank you for that.
Your time is over.
No, he's not going to give you...
We have another question, Dominique.
Yeah, so he let it go. That's fine.
Yes, very nice talk indeed, and clear messages. Let's come back to the videos, and in relation to the discussion with videos, it's really important to understand what are gait disorders, but it is even more important to know what is a normal gait, because you ask us what is a normal ranges of normality for gait velocity. And the situation is that normal gait in France, normal gait is little taught, and Pim, our colleagues, do their best everywhere to teach what is a normal gait in medical schools. So I would like to take the opportunity of this session to know what is the situation about the teaching of normal gaits in medical schools in Italy, US, Canada, Belgium? Could you tell us?
Well, I can't tell you about what happens here or in Canada. I will tell you in the US is quite limited. We put together a course every year, and I bring together nearly 100 residents in training for a 3-day course on gait. And I'm not referring to complex gait analysis or three-dimensional gait. We are talking about understanding the difference between swing and stance, understanding the different muscles, the biomechanics of gait, functional anatomy. Yesterday we heard a beautiful lecture on the structural anatomy, the functional anatomy, and the functional outcome of that anatomy. And so we work through all of that. But that's not true universally. It doesn't happen everywhere. So I don't know what's happening in France. I don't know how this is being done here. or in Canada. I don't know how that's being done. I've offered in the past for ISPRM to put a course together in gait. At the Academy of PM&R, most years I do a 3-hour session on gait analysis, and I usually get surprised that I get a room full of people every time that I give the lecture, and that every time I ask the same question as I ask here, what's normal walking velocity, most people have no idea. So it's, we're trying to change the world slowly. As they say, one step at a time, using gait analysis. I have no idea what's happening in Belgium.
We have course about normal gait, but for when you go to the gait lab, of course, when you go. Yes, we have some course for PM&R specialists who with gait lab course, yes, but don't know the situation in France.
I meant that, unfortunately, there is no, or quite no, teaching of what is normal gait for medical school students at the beginning of their courses. So this is something which is missing, not only for specialists. Of course, it is taught for specialists, but for all medical doctors.
It will be a never-ending story with you, Alberto. Ladies first. Philippe, you already speak twice.
Thank you. Je vais parler en français. Merci. Non, la remarque que je voulais faire, c'est que sur ce projet d'avoir une vidéo standardisée, c'est un bon projet, sans doute pour l'hémiplégique notamment. Mais ce que j'ai bien vu, c'est que c'était entre les barres, donc ça demande quand même un lieu particulier, ce qui n'est pas toujours simple si on veut faire des injections et réévaluer à chaque fois, parce que le patient il doit aller dans un lieu particulier et revenir. Et je voulais dire que pour les patients, notamment paralysie cérébrale, dont je m'occupe, il y a beaucoup de patients qui ne sont pas des marchands autonomes, c'est-à-dire qui sont marchands avec une tierce personne, qui est devant eux, qui est derrière eux, qui est à côté d'eux. C'est parfois uniquement le transfert qu'on essaye d'améliorer. Et il faudrait qu'on laisse une place à l'évaluation vidéo. Parce que moi, je prends beaucoup de vidéos sur mon téléphone, donc je ne suis pas dans les clous, comme beaucoup de collègues. Parce que c'est dans ces vidéos-là, des vidéos fonctionnelles de la vie du patient, qu'on juge, à mon avis, le mieux les objectifs pour ces patients-là. Donc peut-être il y a une place pour les vidéos standardisées des marchands, des bons marchands d'intérieur, mais celui qui doit monter la marche pour aller dans sa douche, celui qui doit faire son transfert avec son père ou sa mère ou son soignant, il faut aussi qu'il y ait une place pour ces vidéos-là. Et là, je pense que la standardisation n'est peut-être pas faisable.
You will answer first.
Well, just to say, you're very right. There's no way to standardize that. It's I get hundreds of family members who brings me little pieces of video. Look at this, look at that, but they show you, look at the knee, and they're showing you their head. Look at the ankle, and so it's very hard. It needs to be standardized, but you can't do that. So I hear your point. Well taken. I'll sit down and stay quiet.
Sorry, Thierry. I just like to make an observation and say that I'm completely agree with you when you say that we have to take account on connection between flexor digitorum longus and flexor hallucis longus, and our experience in tenotomy. We know that if we practice only flexor digitorum longus tenotomy, we have the risk to have a cloto on the hallux. And this is our experience, and I think it's important and to take to take account on this connection. And for the quadratus, le carré plantaire, I totally agreed with Bernard Parat. In our experience, it's important to associate this muscle in the program of botulinum toxin injection. This is our experience.